Well, I'm Dr. David Johnson, professor of medicine and chief of gastroenterology at Eastern Virginia Medical School at Old Dominion University in Norfolk, Virginia. Well, colon cancer, we certainly have seen new screening guidelines. We've seen age reduction is looking at 45 as far as the new norm, but we're still seeing incremental cancers that we potentially could have prevented by an appropriate screening, perhaps, and we'll talk about that maybe at the finish. But the idea that we're seeing these more advanced cancers, even in younger patients, because they haven't been screened and at the time, and certainly the intervention that requires the surgery and then chemotherapy is focused for patients coming back and asking, what can I do? Now, I've got colon cancer. What do I do? You've had the surgery, you had chemotherapy. What else can I do? I want to talk to you about two things: exercise and aspirin. Actionable now. 100% on my side, and let me explain why. The first is a study, very interesting, that was just published in the New England Journal of Medicine, looking at structured exercise after adjuvant chemotherapy for colon cancer. So these are advanced stage 2 or stage 3, 91% I think were stage 3, but these are patients then that came in and they were randomized as it relates to an intervention with an exercise program. And the idea of exercise potentially being mechanistic as it relates to cancer effect makes sense. There's certainly observational data, but the mechanistic effects have been ascribed to metabolic growth factors or inflammatory changes or immune function changes, perhaps sleep effect. These things all, again, relative to potentially a good exercise program and diet. But nonetheless, here is a study that was called the Challenge Study. It was a phase 3 randomized trial, particularly from Canadian and Australian centers, but they were looking at the effects of healthcare education materials alone or materials plus a 3-year structured exercise program in patients who had already completed then their adjuvant chemotherapy after their resection. They actually excluded patients within a year if they had early relapse, just to make sure that they weren't some type of syndromic things that were highly aggressive. But they then looked at the performance characteristics as it relates to the patient's effect, but they also looked at survival, which is really the primary endpoint. And the goal of the exercise program, which was structured over the interventions by in person or over the internet in a sequence of times over the course of the first 6 months. And the idea was to change from a baseline metabolic profile, which they described as a metabolic equivalent task, and they looked at number of hours per week. And they then wanted to increase that over the next 6 months and maintain that then for the next 2.5 years. So a 3-year primary endpoint here as it relates to disease free and survival. Now, the patients were able to structure some things on their own. And when we talk about an increment of 10 met hours per week, it's not too vigorous, but it's equivalent to adding about 45 to 60 minutes of walking 3 to 4 times a week, or 25 to 30 minutes of jogging 3 to 4 times a week. So these are fairly simple and easy, certainly no cost related. But they looked at the endpoint here, and the exercise reduced the relative risk of disease recurrence, new primary cancer, or death by 28%. 3 years. They followed these patients out then for 5 years and 8 years, and the hazard ratios persisted. In fact, they improved even by a point or two in favor of over time. So again, they're talking about very simple things, makes good sense. I love it when they're simple, easy, they don't cost anything to speak of, but the risk reduction here was dramatic. It's something that I think would be actionable now. Certainly the musculoskeletal adverse events that you would say only because the increased exercise were about 7 points higher in the exercise group, but only 10% were actually attributed to the exercise itself. So again, this is a phase 3 trial, class 1 evidence of intervention, very simple, and an endpoint that is definable here is primary recurrence death or a an actionable intervention that would be overwhelming in favor of you got to do exercise. I think this makes great sense. Now, there are two things that when I read this study. One is there was an attrition over time for the compliance and the training. Whether that made a difference would be interesting to see. And the second is whether there's a pedigree or a genomic pathway that may be predisposing to a benefit here for the exercise group, and that's something we've seen. And it's a perfect segue into the next discussion of another very recent study looking at the effects of aspirin as it relates to prevention of recurrence. So again, patients that had cancer and now coming back for recurrence and intervention. So these are patients, this is a particular looking at a subset of an oncogenic abnormality called pica 3CA. It stands for phosphatidylninosol bisphosphonate 3 kinase catalytic subunit alpha. So look at it as a pica 3K. It's an easy one to remember. But this is something that's been important and shown to be significant as it relates to certain populations. It occurs in about a third of colon cancers. In this particular study that we're talking about is 37%. But then it also has some effect on chemotherapy responses. So it's led to a very significant chemotherapy resistance pattern as it relates to epidermal growth factor, and certainly leading to a higher rate of disease progression. So the study here was to look at the effects of aspirin, 160 milligrams of aspirin, and they looked at it in the subgroups here, now randomized to the intervention or not. And the fact was that there was a risk reduction here of nearly 50% as it relates to 3 years. For the follow-up, the hazard ratios are significant in that regard. Very little as it relates to adverse events, 1 GI bleed, 1 hematoma, 1 allergic reaction to the aspirin group, but dramatic effect as far as risk reduction here for the aspirin group, again, for this pica 3 subset. So about a third, this is a study done in the Scandinavian countries, Sweden, Denmark, Finland, and Norway, 160 milligrams. Notably, even in the primary prevention trials, aspirin primary prevention, when it was initially recommended from the U.S. Preventive Task Force in 2016, as a primary prevention, they recanted that in 2022, but there has not been a dose response, meaning higher doses don't have even a greater increase in the prevention here. And this particular study looked at a fairly nominal dose, 160 milligrams, so 2 cardiac aspirin type things if we were using the 81 milligrams in the US. So again, exercise aspirin. I love it because they make sense, they don't cost a lot, and patients are eager to do things on their own. What can I do to help myself? I think we have 2 actionable items immediately that we can start to apply, particularly the exercise, and maybe for sure in conjunction with your oncologist, defining the pica 3CA pathway pattern. Again, a third or so may be implicit that aspirin makes a difference. Hopefully this gives the patients an active intervention, and certainly adding hope is really important to what we do in these cancer patients. So Dr. David Johnson, let this guide you, hopefully, with your new information as you bring hope to your patients with colon cancer. Thanks again for listening.